welcome. Welcome to Massey College and welcome to Massey Dialogues. My name is Nathalie Desrosiers and I'm the principal of Massey College. It's my great pleasure to invite you today to discuss the opioid crisis. I want to acknowledge that Massey College is built on Indigenous lands, the lands of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. It is the treaty land of the Mississaugas of the Credit. We want to acknowledge our duty of stewardship toward this land and the privilege that we have to be here. So today we're discussing a very important subject, and I just want to say how grateful I am to the specialists and the people that we have to help us understand and come to grips with this important problem. And without further ado, I'm just going to pass it to Junior Fellow James O'Grady, who's going to be our moderator for today. Thank you so much, James, for doing this.
No problem. Thank you so much. Hello, everyone. Thank you so much for coming today. This is the 6th episode in the Massey Dialogues. We'll be discussing the opioid overdose crisis in Canada and some innovative solutions to keep Canadians safer. So without further ado, I'd like to introduce our guests who are joining us virtually. First of all is Dr. Christy Sutherland, who's a family doctor and diplomat of the American Board of Addiction Medicine, who works in Vancouver's downtown east side, providing care to Canada's most vulnerable population. Dr. Sutherland is the medical director of the PHS Community Services Society, where she leads a team of physicians and nurses who are embedded in low-barrier harm reduction projects. She received her MD at Dalhousie University and completed her family medicine residency at UBC in 2010. Dr. Sutherland was recognized as the 2018 British Columbia Family Physician of the Year, as well as the recipient of the City of Vancouver Award for Excellence. Likewise, I'd also like to introduce Dean Wilson, who is joining us. Dean is a long-time drug reform activist with a history of activism and work in drug policy, including going to the Supreme Court to keep the Insight drug injection site opened indefinitely. He's outspoken about his lived experience, and we're so great to have both of you here today. Likewise, to my left, we have Dr. Samim Hasham, who's a lecturer at the Toronto Metropolitan University, McMaster University, and Adler College. She is the recipient of the prestigious Spirit of Belonging Award from the Canadian Mental Health Association of Toronto for outspoken commitment and dedication to better mental health, as well as a long history and career in pharmacology. So I'm thankful to have all of you here today as we discuss this very pressing issue. So without further ado, I think I'd like to bring it over to you, Samim, to talk a little bit about, what is the state of the situation right now? How is the opioid crisis being changed over time, and how has COVID particularly affected the crisis?
And that's really important to know. Where do we stand in Canada? Where are things right now? And so, a picture tells is worth 1,000 words. And so if Joe can show the first slide, what I'll do is I'll show you. I can tell you these many thousands of people died, but when you see the slide, when you see the stats, I think things will make a lot of sense. And it'll give you a good snapshot as to where we are. So from 2016 till March of 2022, in Canada, we lost over 30,000 people. So 30,000 families lost a loved one. They belonged to somebody. There were mothers, fathers, sisters, brothers. Over 30,000 people, over 30,000 lives were lost between 2016 and March of 2022. January 2022 to March 22, we lost in Canada over 1,800 people.
Wow.
Just to put this in context for you, 1,800 families are without their loved ones. They lost them within the first 3 months of this year through opioid poisoning. And I'm not going to call it an opioid toxicity, I'm going to actually call it an opioid poisoning, because the poison came from an unregulated supply of opioids. Now there's an economic cost to this, of course. Hospitalizations, emergency medical services, and the human cost as well. And just to drill down to the human cost, if we had a huge plane that could accommodate 400 people, and it went up in the sky, and say one day it just vanished, I think we'd be really shocked, there'd be an uproar, we'd be doing something about it. If the second plane went up with another 400 people, and again it vanished from the sky, I think we'd be trying to find solutions as to what was going on.
Absolutely.
Well, we've had 4 plane loads of people die in the first 3 months of this year alone. So I think to say where we're at, but we're not in a good place in Canada. The States, yes, definitely a problem, but we also have a problem in Canada. As to where this is happening, I think in Ontario we feel, oh, this is a problem of the East Coast. Well, it's not. If you look at this map and you look at the stats, there's some stats that are not even reported by certain provinces. For us, 646 per 100,000 people. So this is per 100,000 people, which means we've lost a lot of lives, right? As to where these are happening, mainly the opioid poisonings, British Columbia, Alberta, and Ontario, but others as well, right? In terms of who is affected, and maybe if we can go to the next slide, well, it's amongst young to middle-aged people between the ages of 20 to 59. And we tend to think that this is just a problem with the young people. People experimenting, people getting into trouble. Well, it's not. It's between the ages of 20 to 59. That's almost a 40-year gap. So we're losing people between the ages of 20 to 59 to opioid poisoning. In terms of gender, the reports are mainly, male and female. Well, we know there are other gender identities as well. So let's just go with male and female. 3/4 of the opioid deaths are happening in the male population. And I think this is important for, policymakers and people who are creating policies around the opioid crisis to understand who is being affected, how are they being affected, and why are they being affected. So if we go to the next slide, why? It's the unregulated supply of mainly fentanyl. Wow. So fentanyl and its analogs as well, but fentanyl predominantly. And a few years ago, even 5-10 years ago, it was heroin, some other drugs, but it's now fentanyl. Fentanyl is a pretty potent drug. And fast forward to the COVID crisis. Well, addiction is a disorder of isolation. And so when COVID happened, we saw a huge increase in the number of opioid poisoning. There was a 91% increase in the rates of opioid poisonings in Canada over the 2 years of COVID. And compare that to the number of people that actually lost their lives. So if we can go to the next slide, we had COVID happening in one direction, addictions and this crisis happening in the other directions. And I don't think we really paid attention to what was happening to people who use drugs. And I say PWDs, meaning people who use drugs, because language matters. We often hear people saying, oh, addicts or opioid users. Well, no, let's call them people who use drugs. Let's use the right vocabulary, because stigma is a huge barrier when people are trying to look for care. So the impact on people who use drugs during COVID was, there was an increased drug contamination and toxicity. You couldn't go to the people that you were comfortable with, to purchase drugs. You had new suppliers and new dealers. There was decreased drug quality and purity. Prices went up. Around the time of CERB, prices went up. I know prices have come down now, but during COVID, the price for drugs really went up. There was also increased violence in the drug market, and this is something that people really don't talk about. But there was violence in the drug market. There were barriers to harm reduction. People were isolated. You couldn't get harm reduction supplies. Services for withdrawal management were not open, and so this just exacerbated the whole problem. And then housing and food insecurity. We have to understand the impact of colonization on the population. We don't often talk about colonization when we talk about the opioid crisis, but there's certainly a correlation. And I hope we can talk about that during the session. But, this should tell you, the impact on people who use drugs, what happened to them during COVID and the opioid crisis.
Wow. Thank you so much. That's really incredible to have a bit more information of the overlaying factors that really on this issue, and to try and create a more humanizing discourse around this. And so I think I'd like to transition over to you, Dr. Christy Sutherland, to ask a little bit more about how did we get here in your own professional career or before, and what is the future of innovative care that you've seen? So.
Yeah, thank you so much. I've certainly changed as a person over the 12 years of my career as a family doctor in the Downtown East Side. The overdose crisis was declared in 2016 here in BC, so half of my career has been during a crisis, which is quite a bizarre series of events. And so I've had lots of time to reflect, why in the world is this happening? Why is the world set up this way? And having all of this death and grief around you, doing so many resuscitations, really invites you to sort of unpack the history of how we got here. And I think, I started out this way, thinking that drugs are illegal because drugs are bad. But that's false. Drugs are just molecules. Alcohol is a molecule and fentanyl is a molecule. And that the reason that some drugs are illegal and others are not is very much based in racism. So let's look at the next slide. There were race riots in Vancouver in 1907. A mob of white people went into Chinatown and destroyed businesses and homes. It made international news. And a delegation came from Ottawa from the federal government to find out what happened. They talked with mostly white people who blamed the blamed the riots on opium. And so that delegation returned to Ottawa and they passed without debate the Opium Act of 1908. So this was the first time that any drug became illegal in Canada. So really it's not that long ago, and it's not the baseline of how society should work. And that we can see as organized crime has driven profits, that the drugs become more potent with more contaminants because profit is what they're looking for. You can go to the next slide. We've been talking about this a long time in Canada. The Ledane Commission was in 1969. It was a Canadian government commission of inquiry that advised criminal sanctions against people who use drugs be reduced, the offense of possession of cannabis be repealed, and opiate users should be offered medical treatment instead of criminal punishment, and none of the recommendations from this commission were implemented. So alcohol prohibition is universally recognized as an absolute disaster. There is young, handsome Al Capone. He was worth more than $1 billion in today's value, and he went to jail for tax evasion. The amount of death, violence, blindness that came about from this terrible system that came from policy it's not debatable about what disaster it was. And so alcohol prohibition ended, but prohibition of other drugs continued and continued to become worse over the next decades. So John Ehrlichman, his name might ring a bell. He actually went to jail for Watergate. He was an advisor to Nixon, and in 2016 he was interviewed by Harper's Magazine. He didn't really want to talk, but I think the reporter sort of put his foot in the door, and this is what John said through the little crack in the door. He said, "You want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did." I thought this was a mic drop moment in policy. I remember when this came out and I was so excited to see drug policy reform, but even the architect of this system that we have today admitting quite publicly that it only was based on racism didn't really create change in our systems. So the next slide. Okay, a U-shaped curve. We love a U-shaped curve in medicine, so let's walk through this one together. This, on the y-axis, is health and social harms, and along the x-axis is different modes of how drugs and society interact. Like, what is our framework for our relationship with drugs as a community? Right now, we're on the top left, so unregulated illegal profits. So organized crime controls the content, the price, and the supply chain, and the recruitment of sales for drugs. So basically, it's the worst case that you could create. And it's the reason that we're in this nightmare of death. That I don't trust organized crime with, like I think we think about even like regular corporations or like a mining company or like a big multinational. They are regulated, but they will always try to maximize profit within those regulations. And so organized crime is not regulated at all. They have no HR department or thought to the environment or even thought to the death of their customers because they are not held responsible for any of those things. So we're in that worst case scenario. There's another pretty bad scenario, and that's unregulated legal profits. So that's tobacco in the 60s and 70s, denying that they have anything to do with lung cancer, advertising in magazines, having sales, being prominent in the storefront, having enticing packaging, and that we don't want corporations to be selling something that is addictive for profit. And so there's always this tension between public health and profit with drug organizations. So we can think about labeling of tobacco, that tobacco companies do not want to have a picture of cancer on a tobacco package. It's bad for business, right? But that we require it through public health. Or we think about, if you look at magazines from the 80s, they had tobacco advertising. We don't have that anymore. Tobacco has to be behind the counter at the convenience store behind a screen. And so these are public health measures that decrease harm from tobacco use. So where we want to be is that public health model, and that can look different for every drug. And that can be based on the mechanism of action of the drug, the danger of the drug, and the route of its use. but we need to move along from where we are right now, and that we need to think about a roadmap out of this nightmare, because continuing to try to trust organized crime to not kill people is not going to work, and that we need a way of creating safety for a community. Next slide. I love this. I got it off Twitter. So I think about this often for my patients, that for so much of the time, drug use is the burden of not using drugs is put on an individual, saying you should make better choices in your life. But I can see my patients are just trying to survive in this huge structural obstacle course of violence that we've created for them, where often they're homeless, doing survival sex work, and they get some drugs, and they go to the drug testing services, and then they say, oh, this is carfentanil, not fentanyl, but they're dope sick, and they have no way to get safe drugs. So they use those drugs. Like they are trapped by structural problems, and it's easy to blame them about making bad choices, but it's so much more complicated than that. And this is another thing from Twitter. Twitter's gold for medicine. Like, I really love medical pearls on Twitter. So Ryan Marita is a physician from the States, and I love this graph. It's so simple. Because people who use drugs and people whose drug use is criminalized is not the same population. For me, thinking about this graph, it's really divided up by my social life. I know a lot of people throughout my life who've used a lot of drugs, and I don't know anyone socially who's been arrested. And I think about my patient population, they have been often arrested for possession of drugs. Not even trafficking drugs, just like possession of drugs for personal use. And that a lot of these lines are racial, so that we can see that Indigenous people and Black people are disproportionately arrested within the war on drugs than white people. And so imagining a world of decriminalization is not imagining some sort of party time for everyone. Like that. Actually, when we looked at cannabis in Canada, cannabis use didn't really go up in youth when it became legal, but it did go up in older populations like boomers. But that decriminalization probably won't change at all how much people use drugs, but it will certainly change the burden of criminalization that marginalized people face. And the next slide, I think, is my last. I just think this, applies to my whole life. That for every complex problem, there's an answer that's clear, simple, and wrong. And wouldn't it be nice if we could just tell people, why don't you stop using drugs, and then we stopped having overdoses? But there's a reason that doesn't work, and it misses the point of these complex systems that have been set up over more than a century that back people into a corner where they're facing this risk of death.
That's fantastic. Thank you so much, Dr. Sutherland. I think you make a great point as well in demonstrating the complexities that overlay the drug crisis, and it's not a matter of personal choice or health promotion, but rather something that requires a structural approach, as well as something that requires harm reduction and creating and humanizing this issue altogether. And so likewise, I'd like to lead the conversation over to Dean. And I'd like to just hear some of your thoughts as well from your own advocacy career, some of your own work as well, and contribute to some of the things that Samim and Christy have been talking about here. So once again, thanks so much.
I guess I would just like to start at the beginning. In 1972, I was arrested twice for possession of marijuana. I became a pariah amongst all my friends' parents. I couldn't go back to my high school where I was a straight A student. I played golf, I played piano, but all that pressure started me on my journey of coping with life with opiates. I carried on for most of my life, but in the 1990s, all my friends started dying of HIV/AIDS because we couldn't get clean needles. And it started me on my political venture to try to change these drug policies. Now you look at needle exchange is ubiquitous with good health care. Marijuana is legal. So it just shows that we've always been ahead of the curve and on the right side of history. And I just wish that drug policy would keep up with the dangers that are on the street right now, because we could we could stop. Well, we couldn't stop it. Drugs are dangerous. Don't get any. I'm not saying anything different. Drugs are dangerous, but if we know how much we take, then they're not as dangerous. Look at fentanyl is used in the hospital all the time, and people don't die of overdose. So as long as there's this criminal element selling whatever it is, we're going to die. But if we had a regulated drug market where people who were registered could go in and buy whatever they needed to cope with their life, it would be simple and it would be over. And the taxes made on that could be used for prevention, for treatment, instead of having this 95% of every dollar going to policing with regards to the drug issue.
Thank you. And also as well, I mean, like you mentioned, in your own personal work, I know, and you work with the Insight, heroin Insight injection site in Vancouver. That's been around for close to 15 years, if I'm not mistaken. And there's been some.
It's not it's not just a heroin injection. It's a supervised injection site. Yeah.
No, appreciate that. So my apologies. Right. So I'd like to also transfer this conversation back to you, Samim, in building off of what both Christy and Dean have been talking about. How do you see the future of this building forward? And
yeah, and the three of us were talking about this last night, and there are lessons learned from the past, as Dr. Sutherland mentioned, alcohol prohibition, and what do we do? How do we move forward? So we've actually come up with some ideas, and if any policy people are on here, or anyone that's in a position to make changes, if we can have the next slide on, we've come up with some solutions that we think will work. One of them is building system resilience. What does that mean? Housing availability, right? Who doesn't want housing? Everybody wants housing, security, economic security, right? Shelter policies. What do our shelter policies look like? Recognizing and addressing criminalization as a source of stigma. And stigma to me is a huge problem, and I think we should disrupt stigma. Not just say stigma is a barrier, but I think we should just disrupt all these stereotypes when it comes to stigma. Provide culturally safe spaces for people to get trauma-informed care and not to be re-traumatized, because that happens quite often. And I think there's a lack of trust and safety for those accessing services. And I think disrupting stigma is going to take a lot of work, but it needs to be done. Language matters. We've got to stop calling people addicts, and actually call them people who use drugs. This idea that this medicalized and criminalized approaches to this problem is clearly not working. We can see that in the stats. We can see that in what Dr. Sutherland presented. So language matters, right? And also, setting up appropriate harm reduction and treatment interventions. Naloxone, safe injection site, drug checking services. We certainly need them. I think we need them a lot throughout Canada. And you have little pockets of cities that are providing it, but it's not across. And then, of course, we have methadone or Suboxone, opioid agonist treatment. But methadone is not for everyone, and I think Dean can also speak to that later. But some people may not choose to use methadone. Methadone's not for everyone. Suboxone's not for everyone. So we can't have this one solution for everybody. It's complicated, right? So what do we do for people who can't use methadone or can't use Suboxone? We've got to think about those people as well. And then health equity itself, right? And I said before, we've got to understand the intersection of this colonization and poverty and homelessness and how these people are disappropriately affected by colonization and the impact of colonization, and racism as well. I mean, racism is at the center of the opioid crisis, and Dr. Sutherland sort of alluded to that. And if I can just go back to the slide again, there's something that I think is very important, and this is personal capacity. And I'm not sure if people have heard about this, but for me, reflecting on personal capacity is so important, because it reminds us that people are not just, objects that can be acted upon. They're citizens with freedom and responsibility, and they need to be treated with respect, with their personal capacity intact. And then social justice, right? To ensure that all systems are equitable for everybody. The disadvantaged, the advantaged, everybody should have the same lens of social justice. And I think Dr. Sutherland would probably like to speak to the other two, because I think she's very passionate about those two as well.
Please.
Yeah, I was going to say, I think it's so interesting to talk about stigma and language because in medicine, we like to talk about the risk factor rather than sort of the moral judgment of someone. And I think that that's what's important for when we're talking about risk of death. That whether you have a diagnosis of substance use disorder more formally from a physician, from the DSM, really doesn't matter that much in your risk of death. That just anyone who uses drugs is at risk of death right now in Canada because you have no idea what it is that you're using. And we can look at the drug checking data to see the incredible variability in even if someone's buying fentanyl, how much fentanyl is in there, with the contaminants from benzodiazepines. And then I think about people using party drugs or psychedelics or cocaine on the weekend, that everyone is at risk of death because they have no idea what they're buying and there's no recourse to change a system that is totally unregulated. And that thinking about the idea of methadone, like the medical intervention, it is such a wonderful intervention for when it works. It is an incredible amount of body of evidence, like since 1960, the first methadone trial was here in Vancouver, that it saves lives. But if someone only uses once a month, you wouldn't put them on methadone because you would increase their opiate tolerance and put them on a daily opiate when they were previously using once a month. But that person is at incredible risk of death because they have low tolerance to opioids and then might start using opioids like on a weekend if they're using a bit of stimulant and then want to use some opiates to fall asleep, that there's no medical intervention that prevents them from dying that night other than just a supply of drugs that they could access.
Wow. I guess that also begs the question of...
Could I say something?
Yeah, I'm sorry. Go ahead, please.
Methadone saved my life without a doubt. And through methadone, I have now presently got 6 months in for the first time in 50 years of not using a legal drug. And so there are many ways of trying to attack this, but sobriety is just one small aspect of it. Some of us will attain sobriety, many won't. But are we going to crucify those that don't? And sentence them to death? I lost 5 people in a 36-hour period 2 weeks ago, and it literally crushed me. 2 of them I was quite close to. And I don't know of anybody suffering those kinds of losses outside of war-torn places. And yet this is in Canada. And it just angers me that I could go out to a bar and act like a complete buffoon and maybe even go home and rough up my family. And the next day I'm just, he's just a drunk. But if I hide behind a dumpster in some seedy alley in Vancouver, I'm some animal who should be caged. That is not right, and it's got to stop.
Absolutely. I think, yeah. And I think this is a question I'd like to ask for all of you, is, unless either of you have something to add.
I agree. Like, it's baffling to me. I think about the safety that I enjoy in my life. Like, my life has been so safe and so lovely because when I use drugs, I go to Shambar and have their fancy cocktail of the night. And that alcohol, when we look at the molecule itself, is quite a bad molecule for a human. Like, it causes dementia, it causes cancer, it causes liver failure, increases risk of motor vehicle accidents, domestic violence, as Dean pointed to. Like, it's quite a risky molecule to engage with. And yet I do, and I do it with the optimizing of my safety because of bylaws that require that a restaurant I go to has cleanliness, that they meet health codes, that they have a supply chain that is regulated, that I know what is like the percentage of alcohol in the drinks that I consume. And so I think about that luxury of safety that I have because the drug I use is a drug that's legal. And then I think about my patient population and that they are missing that luxury of safety. And so that's always been my goal in the clinical programs that I create, to try to replicate safety that I enjoy. And like, I even think about, because PHS is a housing-based organization, and I have a house where I'm safe and I have a door that locks and water that runs. So like, I have a lot of luxury and safety in my life that everyone in Canada and in the world should have access to. But I reflect a lot about that idea of safety and what a privilege it is, and that people who use drugs that are not legal have no way to access that safety. So it's not that they're making bad choices, there's no path to get those drugs in a way that's safe.
And I think if I can just add to
Go
that,
for it,
safety
please.
is so important. I mean, you want safety when you're consuming alcohol. I would want the same thing too, or consuming cigarettes. But when it comes to opioids, there's the stigma attached to it. And that's what I was talking about, this disruption of stigma when it comes to people who use opioids. It's just this huge lens that people have, which is colored, like people who use opioids should not use it in a safe environment. And I think this is what's creating this toxic, drug supply, the unregulated toxic supply, and hence numbers that we're seeing. And behind every number, I'll go back to it and say there's a family, there's a family, there's a person, there's a name. The person that passed away had a name, and they belonged to someone, and they were members of our society, they were Canadians. And so if we want safety, why not accord them the same safety as well?
Absolutely, and opiates are an inherently more safer molecule than tobacco or alcohol. Like opiates don't cause cancer.
Yeah.
They can cause like some hormonal disruption and bone mineral density loss, but like it's quite mild when you compare to like a cancer-causing agent that like reduces your life expectancy, like alcohol and tobacco.
And I also think we have countries that have, like Portugal comes to mind, right? They've done a lot of experimentation and what should, they've done the prototype of what safe supply can look like. And so we have lessons out there in Sweden and in Portugal that we can look to and say, what can we do in Canada to create a safe environment that's safe for everybody? And I think it's time to change the conversation. We've seen enough stats. We know what's going on. It's not time to do something about it. Yeah.
Absolutely. And likewise, I think you make a great point as well of it's arbitrary in many ways. And so I guess something I'd like to ask for both of you, if you don't mind me asking a question about Vancouver. It's just one of the things that over here, at least in Ontario, we see often Vancouver as both an epitome of, safe injection sites and progressive models, but at the same time, encampment clearance and the tension between progressive values and creating safe spaces and then destroying others. So what do you think are some lessons that we can learn from Vancouver that could be applied elsewhere in Canada or more broadly? What should we be thinking about from Vancouver, I guess, if that makes sense?
Well, one thing, we need a lot more Dr. Christy Sutherlands right across this country. And second of all, we've got to figure out how we're having this health issue, as Dr. Sutherland was pointing out last night, which is provincial, and the prohibition, which is federal. Fentanyl doesn't kill people, prohibition kills people. I buried my first friend in 1969 of a heroin overdose. This is not new to me, but we've got to figure out, are we gonna follow the American model where we're gonna jail everybody? Or are we going to try to integrate people back into society? Because most drug addicts don't want to cause any problems. If they had access to their drugs, you wouldn't even know they were around.
Yeah, I think as well, like Dean's point is so good about the policy issue. So I had a moment that gave me goosebumps about a year ago. A colleague of mine who's a librarian said, a program will never solve a problem that's created by policy. And I was just like, I went white. I was like, oh my God, that's my whole career. I'm trying to make programs that address policy problems. So here I am with my incredible political team working our guts out to try to get safe supply to people, but that the problem's created by the criminal justice system. And we're trying to shoehorn this medical solution that is inelegant and hard to scale to address a problem that we've created through criminal justice policy. And so it was doomed to fail. And that it's, as well, so disproportionate to the amount of the crisis. As Dr. Samim said, that if planes were dropping from the sky, we would do something drastic. There would be incredible outrage. But instead, we have clinicians and nonprofits and teams trying desperately to work as hard as we can. But the proportional response, in my program, I've started probably 600 people on safe supply over the past few years, but 600 people die in 3 months. So how is that a response provincially to the amount of death that we've seen?
I have this joke that I say, what do you call a supervised injection site for people who drink alcohol? It's called a bar. why can't we access our drugs similar to nicotine, alcohol? Sugar kills more people than any drug in this any fentanyl does. So if we could have a regulated supply, it would change a lot of things, and it would save a lot of lives.
Yeah, and I think part of that regulated supply is price. That drugs used for euphoria and used for fun, like not a medical indication, I think people should pay for it. And then we can look at tobacco and alcohol and see that there's really good evidence in Canada and internationally to show that as we adjust that price up and down, we can see harm go up and down. So the WHO has just called for a mandatory minimum alcohol pricing internationally because we can see a set price of alcohol decreases morbidity and mortality. And so I think the same for opioids and cocaine and psilocybin. Wouldn't it be nice if you could get organic, fair trade cocaine where those farmers in Bolivia were paid appropriately and not had their land stolen by organized crime and with pesticides, and that I think about how I buy coffee, that I'll buy the most expensive artisanal coffee if it has like fair trade, organic, and a picture of the farmer. And then I think about the harm to supply countries for supplying North America with drugs. That there's huge harm to these countries in terms of violence, organized crime, and environmental costs, and cost to Indigenous people for their land to provide us with drugs. So I think a lot of people would use cocaine if it was organic and fair trade. And that we don't need to think about cocaine as evil because it's just a molecule and people are using a lot of it, and that there would be less harm internationally if we had a legal regulated market.
Samim?
I think you were asking what can we learn from Vancouver, and I think we can learn a lot from Dr. Sutherland and Dean for sure. But I think we know that the most cases are happening in British Columbia, Ontario, and Alberta, and so they can be the leaders. I think these three provinces can actually come together, look at what people have done. There's proof of concept of different ideas in all three provinces, and I think they can be the leaders and say to the federal government, to have all the provinces and the feds come together on a platform and say, this is a problem. Let's look ourselves in the mirror and say, these are our people. These are Canadians who have passed on, and what can we do to keep the ones that are using safe? So I think we just need the provinces and the feds to come together and have policies. I get it, policies, but this unregulated supply. And I think Christy mentioned this, Dr. Sutherland mentioned this. So we have the tainted supply with opioids, but we also have benzodiazepines. There is a benzodiazepine, Tizolam, which is quite potent. And when that is mixed with your opioid and then you have a stimulant, often people don't know, they think they're buying fentanyl, but there might be this benzodiazepine, Tizolam, or there might be adulterated with cocaine. And reversing that kind of overdose is pretty complicated. So I think just having this regulated supply, but having everybody come on the table together, look each other in the eye and the mirror and say, let's do something about it.
Wow.
Yeah, I'd like to say I love that pragmatic approach, because we just have to sort of be existing in reality. Like sometimes reality is in a very uncomfortable place, but I try to be here. And that people use drugs. It's a normal part of being human. But that this poisonous death of IV high potency fentanyl is a creation of prohibition. And that it will take a lot to unpack. Like right now I'm prescribing fentanyl for my patients, but I hope in 10 years we have like a cooperative opium den. And so people, it's smoked, so it's not injection, much lower potency, observed dosing in a payment model. Maybe it's owned by a family and they do fair trade with a farmer. Like that, how we are today, this nightmare that we're in, is a nightmare of our own making from our own policy, and that it's gonna take a lot to unpack. But that we just have to be realistic that people use drugs, it's a normal thing to do, and that some part of that population shouldn't be punished with death.
Amazing.
Well said.
Yeah, and on that note, I think we open up the floor to questions, either from the in-person or virtual audience. Whoever speaks first.
And Dr. Sutherland agreed to answer all the questions.
Yes, exactly. So.
Yeah, I love a spicy question.
I'm just teasing.
I like the spicy ones.
We'll give the hardest ones to you.
Yeah, exactly.
I think we have one member of the audience here.
Hi, yes. I'm just wondering, it all sounds so very sensible. Why are the policymakers not listening to you? Anybody?
Oh yeah, I have lots of ideas.
Well,
Go for it,
Go ahead,
Christy. I think you have lots to say on this.
I'll let Dean go first. He's
I've
working the
been
longest.
saying the same thing to Health Canada since Alan Rock was the health minister. I've been there yearly. I keep telling the same thing. Nothing changes. So somebody must have an answer. I certainly don't. Dr. Sutherland?
Well, I think this is like the curse of pragmatism and living in reality. And it's why I love harm reduction. I love things that are pragmatic to say, okay, you're sharing needles, and so you're getting HIV, here are some clean needles. It's direct action that is pragmatic, that acknowledges reality. Like if I was an abortion provider, I'd be on that ship in international waters going around providing abortions in international waters. Like I love a direct solution to an issue. And that I think we have to move forward. I'm so excited for decriminalization in BC, because to me that is like one step forward that is so key in dismantling this terrible infrastructure that we've created through policy, and I think it's going to snowball, and I'm very excited for it. I think that times are changing because of the amount of death. But that I think it's so sad that we have to have more than 30,000 Canadians die without seeing really the drastic drug policy changes that we need. I think that the war on drugs has been a very popular political item. That it seems like appealing to the public to arrest people for using drugs, and that it's quite nuanced to unpack and see the harm that comes from that it hasn't decreased drug use. Drugs are easier to obtain, they're more potent, and they're cheaper than they were in the 80s. So we've had decades of expenditure of billions of dollars on the war on drugs, and it's had the opposite effect that it intended. And so I think that pragmatism and that coming from a place of love, that people have died who we love, that politicians will be seeing that the way to get reelected based on a war on drugs is not the way to go for Canadians, that we've changed our minds and we want practical solutions that have good impact and outcomes, and we want the outcome to be less death.
So I think,
Hey, let's face it, this war on drugs have won.
And it's very expensive. Like, it's quite a kick in the teeth. I'm doing primary care here in BC, you know what I mean? Like, renting my apartment and driving my bike everywhere. Like, we're working so hard. But to think about the billions of dollars that are spent on enforcement internationally for the war on drugs, it just sort of makes you sick when you're like, oh, think of like the increase in wage to kindergarten teachers and the roads and the like forestry services and like, you know, the environmental impact that money could have that we're spending on prohibition that only causes harm.
And I think to add to what Dr. Sutherland and Dean have said, one is I'm always hopeful. I think there's hope with this. The more we talk about it, like the more Massey College has these sessions, the more people understand what the issues are. Because we can, you know, you can read something in a newspaper, but to have some, you know, to have people invited to talk about the problem, I think the fact that we're talking about it at Massey is huge. The other thing I think is we need to change the way we talk. We need to have some change talk in here. We need to talk about the economics of the opioid crisis. What are we losing in terms of human lives lost? What's the quality of life that's lost? What is the impact on the emergency medical services? We're all talking about the EMS and how they're all stretched. Well, you know, they are providing the care to some of our people who are overdosing as well. What about hospitalizations? We've got a crisis in the hospital system. Well, you know what? Let's do something about the opioid crisis and you might save some money. So I think we also need to change the way we talk about it in terms of the economics of the opioid crisis, I think. But I'm eternally hopeful. So I think we're going to turn this around and we're going to change things, for sure.
We have another question.
Thank you very much. This is certainly a very enlightening discussion and also a very progressive one because I have not, I'm from Africa, Kenya. I have not encountered a discussion that talks about drug use in the way that it's being addressed here, where the emphasis is to decriminalize, to legalize, and allow people to make healthy choices. But the repercussions are evident. Loss of life is really catastrophic. But my question is this: how much of this discussion goes towards prevention? And there are concurrent programs that are teaching or maybe dissuading those non-drug users from getting into the habit of using them, because obviously the danger is clear. Thank you.
Yeah, I think that's
Can I
such a
just
good
say
question.
something? 95% of every dollar spent by the government on the drug issue is policing. So only 5% goes to treatment, prevention, harm reduction. It's just not fair.
Yeah, I think that's such a good point, and that prevention of drug use is also a very nuanced issue, I think, because we don't really, you know, a cop going to a school and saying don't use drugs, like really the evidence has not shown that that worked well. And so to me, prevention for drug use is to have kids growing up in households where they are loved and they are safe, and that they have access to culture, so that they're speaking their language of their you know, their family and their heritage, and that they have enough foods, they have food security, and that they have education, and that they're on a sports team, and they have friends, and that they feel secure in life. And so that's a complicated intervention to create for Canada, but I think a good goal to have as a country. But that at the same time as we have prevention, we can't have it to be this cliff that if you do use drugs, like you're 18 and you go to a party and you decide you want to use some E, but it had fentanyl in it and now you're dead. Like to have this cliff that people fall off of because they only had access to the unregulated market. Like that's sort of what I see my job as, but I think prevention is a huge topic because it has to do with the quality of life for all of Canada and things like domestic violence and food security and poverty.
And I think just to add to what's been said already, remember we talked about building system resilience, you know, housing, economic security. Those are all part of prevention as well as talking about this in schools as well. I think, you know, we need to have this open dialogue with students at school. What is an opioid? You know, people don't realize, we think of heroin and fentanyl and their analogs, carfentanil, as opioids, but codeine also is an opioid. Morphine also is an opioid. Codeine is broken down into morphine pharmacologically. So to have a more robust and broader conversation about what is an opioid. You know, the opioids that we're talking about here are fentanyl and their analogs, but it doesn't mean that codeine is not an opioid. That's an opioid too, and so is morphine. So to have this conversation when we talk about prevention is what is an opioid? And what is the pharmacology of a certain opioid that one has to be more careful about if one is to use? So I think that to me would be the kind of education that I think should go along with all the policies that go with regulating the drug supply. Both go hand in hand as part of harm reduction as well. And then of course having naloxone available in all schools. I think naloxone is so important to have available in all schools. Like 5 years ago, at Ryerson, we started training the nursing students on naloxone use, and it wasn't done until then. And now, you know, I think every university is providing naloxone training and has naloxone on board. So it's just planting the seed and then, you know, having it grow. I think that's what we need to do.
I totally agree. Like people need true facts, not to be scared of things. Like we don't want this like fear-based information system for kids. We want youth like to know. I have a niece who's 7 and she asked me, what are drugs? And I was like, oh, I am so excited to answer this question. Like I don't even know if she knows what I do for my job, but I just was like, oh, I'm so glad to talk with you about drugs because it's so complicated and there's so many different ways. We have drugs that are prescribed and drugs that aren't prescribed, drugs that cause euphoria and drugs that don't cause euphoria. Like that there are so many layers and to the complexity that I think that youth would really appreciate having information about. It reminds me of like sex ed. Like you know that youth have to have information and condoms, and then we have less teenage pregnancy that's unwanted. You know that people need information that's real.
You know, we hear about treatment, and we're all for treatment. We're not against treatment, but the government won't fund treatment either. So for them to say we only support treatment, then put the money where your mouth is and supplies treatment.
Yeah, I look forward to the day that I'm out of business. You know what I mean? Because that people don't have the issues anymore, and I'll go back to doing pap tests and blood pressure checks. then that I would love to see increased funding for treatment and a robust treatment system. Because right now, trying to get a patient into treatment is quite challenging. They need to see our social worker. There's a lot of paperwork to fill out. There's often a wait list. And that the other complicated thing about treatment is that often you can't do acute withdrawal at treatment. So you have to sort of line up your time at inpatient detox to your treatment intake date and have like a transportation arranged for the middle and the dates to line up. So it can be very challenging for people. So increased funding and increased infrastructure for a system of treatment is something that I think would be beautiful for Canada. And that's not in contradiction to wanting a legal regulated market. I want both in parallel.
Is there any other questions from our remote audience, perhaps? No? Otherwise, I'd just like to say thank you both to all of you. Samim, Christy, Teen, thank you so much for all coming today, and as well as everyone who's attended both in person and virtually to this talk series. Now, is there anything else you'd like to add? So, final message to the world.
I just like to say thank you to Massey College. It's been a highlight of my career. But in the words of Nancy Reagan, just say no to the war on drugs. Thank you.
And with that, we'll close. That's perfect.
I just want to say thank you so much for inviting us. Like, this was a very robust conversation. I think we should have more of these conversations, and hopefully, people online and people in the room will go back and talk about this at their dinner tables and Christmas and whatever celebrations are coming. Because the more we talk about it, the more informed we will be. And I think it's time to change the narrative to what was to what can be. What are the solutions? What can we do to save lives?
Perfect. Thank you so much, everyone. And with that, have a great evening. Take care.
Thank you.